Hello, welcome everyone to today's endocrine grand rounds. I had just done my grand rounds a few weeks ago, but since Zach couldn't do it last week and we made some adjustments, um, I decided to do this one instead of canceling it. So I'm going to talk to you an update on beta cell replacement. I have no conflicts to declare. So I'm going to give you just a broad, perspective on why is beta cell replacement something that is important. Then islet structure and function. We'll talk about pancreas transplantation, auto transplants, allo and stem cell transplantation, where there has been some significant amount of work in the last 2 to 3 years. Some of the outcomes related to these and their limitations and how people are working to help overcome the limitations of these different methods. So obviously, it's been 100 years, slightly over 100 years since the discovery of insulin. And over this period of time, particularly for type 1 diabetes and to a large extent for type 2 diabetes, insulin has been the mainstay of treatment, and progress has been made in terms of different types of insulin. So starting initially from beef and pork insulin to biosynthetic and then recombinant DNA technology and now the analog insulins. So we're widely using these systems, and of course, with new devices and sensors, there's been much progress to try and improve control. However, despite all of this on insulin therapy, when you look at this data, looking from the type 1 diabetes exchange between 2016 and 2018, you see that the average A1C for children less than 13 years who were on just insulin injections was 9%. Those who were using pump was 8.7%. And then you can see those who are using a sensor augmented pump, it was still at 7.9%. And these numbers are slightly better for individuals who are over 26 years of age, but still you see that the differences in, the targets are way, the recommended target is much lower than what we have been able to achieve over this period of time. These numbers have improved, but still there is a lot more that needs to be done. So when you look at the glycemic parameters reported by beta cell replacement and automated insulin delivery systems, what you can see is that nowadays, since we are using the continuous glucose monitoring to assess glycemic control, we are looking at time in range, time below 3.9 millimoles or less than 3 millimoles, which is less than 54. And then the coefficient of variation in glucose. So what you find here is that the traditional continuous glucose monitoring plus the CSII, you get about 67, 68% in range. In the high risk individuals with type 1 diabetes, it's about 59% time in range. The target is 70%. So there are some open systems, the do-it-yourself systems. So these have a bit higher, but they're not that widely used. But they still have high rates of hypoglycemia. The percent time in low is quite high. On the other hand, when you look at islet transplant from the data from the islet transplant registry, these are for allo transplants, those who have not been, who don't require any insulin, the time in range is actually 91%. And particularly important was the time low was 0.3%. In fact, these islet transplant patients were selected because of their episodes of severe hypoglycemia. That was one of the inclusion criteria for the islet transplant network's trials. So you have very low rates of hypoglycemia and a significantly higher rate of time in range. So certainly, at this point, if you have to say which of these will give you better results, it's certainly islet transplant. But of course, there are limitations on these, which we will look at and see why. So the thing is that the insulin injections and pumps and all of these are very focused on just insulin. They don't take into account what else maybe the pancreatic islet may be doing. And also they are based on algorithms which are not strictly physiologic. So the islets have, they only comprise about 1% of the pancreas. They have about 15% of the blood supply of the pancreas, and that is because they are highly vascular, and this vascularity is very important for their function. And the reason I bring this up is because when we do islet transplants, revascularization is a significant issue. If you don't revascularize well, the functioning of the islets will be inadequate. The human pancreas contains about 1 million islets, and each of them have about 2,500 cells. So the cellular organization has a clear homeostatic benefit. There are clusters of each islet cluster. There are different shapes and sizes, and we don't know exactly how they, how the shape and size will affect it. But certainly the composition was something that is important. And so this is looking at the different components of the islet. And when you see this, this is the beta cell. There is an input to it from the other cells and also from other neurotransmitters and other paracrine and endocrine factors that regulate islet function. There is the blood vessel, there are the neural structures, and then you have GLP-1, glucagon, somatostatin, and other factors.
You're on the mute. You're on mute. Cannot hear. Okay.
Okay.
Go back. So let's see who else is. Okay. All right.
Okay.
Sorry about
You're
that.
okay now?
Yes.
Okay. So, so these are the different types of cells that are there in the islet. And one of the reasons I bring this up is because when I later talk to you about stem cell derived islets, we really are also looking there to the composition of the islets, because what we find in some of these is there are cells that shouldn't be there and there are fewer cells that should be there. So that is an issue that needs to be addressed going forward on how we, design the use of these different methods of developing islets through the stem cell process. So I'll go through the different things. There are 3 ways of replacing beta cells. One is to use the pancreas. The other is to use islets. And the third, of course, is to use stem cells, which can be differentiated into islets, so you can use just beta cells. So the pancreas transplants have been the ones that have been, from a clinical perspective, been for the longest. The first pancreas transplant was done at the University of Minnesota in 1966. And since then, there has been progress in a number of aspects of this. Particularly, there are two areas where the pancreas transplant has changed over time. One is related to the use of what immunosuppressants we use. That has advanced where we use the least islet toxic immune suppressant drugs. The second is what are we going to do with the drainage of the exocrine pancreas? So initially, a lot of them used drainage to the bladder. Now, almost always we're using drainage to the duodenum or jejunum. So that is the procedure. So right now, mostly rely on enteric drainage via duodenojejunectomy. And this particular procedure, has had significant improvements and is fairly standardized now. Now, this is the number of pancreas transplants that have been done in the United States, looking from 2005 to 2021. So one of the things we see here is the number of pancreas transplants is somewhat constant. It had gone down a bit, but right now it's somewhere between 800 to 900 pancreas transplants. This is the simultaneous pancreas and kidney transplant. There has been a significant decline in the pancreas alone and the pancreas after kidney transplants. So these are very few that are done now as opposed to this. And the question that has come up is why has this not gotten any better? This is the retransplant rate for the different types of pancreas transplants that have been done over the last several years. Because one of the concerns that had been there was that historically, pancreas transplant was considered to be with a high rate of early allograft loss, frequent complications, and significant morbidity. However, when you look at the latest data, what you have is that there is a very high survival rate, ranging from 96% to 98% at 1 year, 90% survival at 5 years, in all the three different types of pancreas transplants. So when you simply look at the patients who are waiting for a transplant, their mortality rate is 60%. So you have a significant improvement in survival for patients who undergo this procedure. The early technical failure is very low, somewhere between 5 to 7% now for all of these different procedures. And the 1 year graft survival is 91% for simultaneous pancreas kidney transplant and 87% for pancreas transplant alone and 86% for pancreas after kidney. So the kidney graft survival, in the same is about 95% nationally at 1 year. And at 5 years, the pancreas graft survivals are 80%, 67%, and 62%. So there is good data to suggest that these will work very well. So what we have is that the functioning of these grafts and their ability to maintain good function over a prolonged period of time has been well demonstrated. And unfortunately, one of the things that we have is that we are concerned mostly about how many of them can be insulin free. So if you look at the number of people who can be without insulin, and you compare pancreas transplant versus islet transplantation, what you find is that insulin independence with islets is much lower than with pancreas transplantation. Pancreas transplantation still has a much higher rate of success. And that may be related to the different factors, particularly the environment in which the islets are located, and also the damage that occurs when we do islet isolation procedures. So the half-life for simultaneous pancreas kidney recipients, for the kidney, because one of the things that was initially of concern was that when they did simultaneous pancreas kidney transplant, that the kidney transplant would not last that long. And that is no longer an issue. There are also now a number of studies that have looked at the outcomes in terms of what happens to the complications of diabetes, including diabetic nephropathy for the subsequent to the transplant, retinopathy, cardiovascular disease, and diabetic neuropathy. And fairly uniformly, what we find is that patients who have undergone pancreas transplantation do better. Their rates of complications are decreased, and their time to reach more advanced complications is increased. So there are benefits not only in terms of glycemic control, but also the outcomes from the complications of diabetes. So at this time, what do we have in as to what the recommendations are for patients with type 1 diabetes? Depends on their, if they are individuals who have end-stage renal disease, if they, we either have to do a simultaneous pancreas kidney transplant or a pancreas after kidney. So if there is no suitable living donor or expected time on dialysis is less than 1 year, then you do a simultaneous pancreas kidney transplant. Suitable living donor plus expected time on dialysis more than 1 year, you do the living kidney donor transplant first and then do the pancreas after kidney. And of course, for those who have severe metabolic complications, such as recurrent episodes of hypoglycemia, marked hypoglycemia, ketoacidosis, incapacitating problems with exogenous insulin, failure to prevent acute complications, then you can do a pancreas transplant alone. So, I think that they can't see the slide. They can't see the screen sharing. Kelly said she's coming back. Can they see now?
Okay.
You can?
Yes.
Okay. Okay. Thanks. So, I can't move the slide. Okay. So this is a recent article in JCNM about pancreas transplant, current challenges, considerations, and controversies. These are from the pancreas transplant surgeons up the road at IU. And so they had commented about this thing that pancreas transplantation reestablishes autoregulating source of endogenous islets, insulin responsive to normal feedback. So it gives you a good physiologic response. It has the advantage of freeing people from taking insulin shots, and the rates of hypoglycemia are also much lower. However, it is still considered a treatment rather than a cure. And they point out in this article that when you go through the ADA recommendations or ACE or whatever you want, and look at the treatment algorithms for type 1 diabetes, transplant doesn't show up. It gives you it'll say, basal insulin, bolus insulin, pumps, all of these things. And same thing for type 2 diabetes. They'll give you all the medications, but transplant doesn't show up. So, whereas it's the only thing that actually normalizes blood sugar. Everything else keeps you somewhere near, but you don't get it to this point. And so one of the problems is that, there are not that many centers that do it. And about 75% of the all the transplants that are done in about 30% of the transplant centers. So it's concentrated in certain things. And the number of centers that do more than 10 pancreas transplants per year is not very high. So this is a limited number of facilities available. Yes, there is a short many. If you can't transplant everyone because there are not that many available pancreases, but not all available pancreases are utilized because there are not that many centers. So they recommended that we do a better job of identifying patients who would be good candidates and not hold off till they are really very sick, in which case the procedure itself becomes more complicated to use. So this is a very useful procedure that is vastly underutilized, because this is the technique is fairly standard and is available. Now, on the other hand, when you look at islet transplantation, the first islet transplants were actually done much earlier, but they all failed. And one of them, of course, they didn't know much about how to isolate it, but they put fragments of the islets or pancreas into the body. And of course, there was not well developed or even rudimentary immune suppression agents that were available. So the initial efforts were not that very successful. Much of the progress has been since 1970s, when the procedure for islet isolation using collagenase digestion and density gradient centrifugation to separate the islets was developed, and over time, this has been the procedure that has been most widely used. Much of the progress since the 1980s was related to better isolation. And in 2000, the development of the steroid-free immunosuppression protocol from the Edmonton group that actually kind of accelerated the clinical islet transplant programs. And in 2016, the NIH-sponsored trial of the Clinical Trial Transplant Consortium published their results showing that this procedure can effectively replace the pancreas transplantation as a viable procedure for the treatment of type 1 or type 2 diabetes. So there are three types of islet transplantation. One is allotransplantation for type 1 diabetes. Then you have autotransplantation for those who are undergoing chronic surgery for chronic pancreatitis. And then you have stem cell therapies, which are still investigational, but there's been significant advance in that area too. So the procedure for islet isolation is mainly collagenase digestion, and then you put it in the Ricordi chamber, which basically shakes the whole mixture well, and then you digest the pancreatic exocrine tissue. Then you do and wash out all the extra tissue. Then you do the centrifugation with gradient, Ficol gradient, and then this is cultured overnight, and then the highly purified human islets are transplanted into the portal vein, into the liver by using with an interventional radiology technique. So for autotransplantation, it is done either the same day or the following day to get the islets into the portal vein. So these are some patients who have had auto islet transplants, and you can see here this is an individual who had who was C-peptide positive, but was on an insulin pump. So you can see that there is some control which is much better than the larger fluctuations that you see when they are not with just the pancreatectomy. So with the current pump technology, you can actually get, especially overnight, good control. They do have some problems with meal-related blood sugar rises, even when they are insulin, C-peptide negative. And this is someone who is insulin independent, and you can see that there is a very tight control of blood sugar that we get with successful islet autotransplantation. So these are the results from the centers with a high volume of islet transplantation, auto islet transplantation. And what you see is the insulin independence rate, 32% at 1 year, 24% at 2 years. And here, and this is at the University of Minnesota, which has the largest experience. University of Cincinnati has 40% 2-year insulin independence rate. And one of the reasons is that the University of Cincinnati is mainly Cincinnati Children's. And so there's a higher success rate and insulin independence rate among children than in adults. It's higher for those who have genetic forms of pancreatitis rather than alcoholic pancreatitis. Alcoholic pancreatitis has the least successful rates. And then this is from Leicester in the UK. This is from the Cleveland Clinic. So approximately 25 to 30% of adults and 45% in children is what we have in terms of insulin independence. So both for pancreas transplantation and islet, whether it's islet allotransplants or autotransplants, the previous goal was, or the benchmark was, insulin independence. But currently, we are looking at that may not be the best outcome measure, because you can still be on insulin but have excellent control. So using a different way of looking at it, what we call the beta score, we can see that you can improve the quality of life of individuals who have had total pancreatectomy or who have markedly fluctuating blood sugars with type 1 by doing an islet transplant, although they may still require some insulin. So this is from the consensus panel that looked at the role of, what is the, this is an international consensus guidelines. So they look at what are the outcomes, and what you see is that there is improvement in quality of life. Pancreatic pain is relieved, reduced medical utilization. So you can see here that other than this, the evidence quality assessment, you see it's moderate for this and low, although they have a level of agreement that it is fairly strong. What you find is that most of these studies are, obviously they are not double blind, you can't. It's also not randomized controlled studies. These are all observational studies where they have done these procedures and looked at what happens to the outcome. So we don't have a large randomized control trial. We have taken patients with chronic pancreatitis, randomized them to one or the other, and done these procedures. These are all observational studies. So, they have looked at what factors associate with favorable or poor pain outcome, which is the major outcome that they're looking for, because pancreatectomy is done for pain relief. And what you have here is that for selected patients, with chronic pancreatitis, that's why it's very important to select the patients properly so that the outcomes can be better. So the quality of life on average is improved. We have been trying to look at what else can be done. Dysmotility and central sensitization of pain have been recognized. So we've been part of the long-term outcome study for TPIAT. And one of the interesting things is that there are certain pain receptor gene polymorphisms that actually tell us that some of these patients will have pain even after the pancreatectomy is done. So there are certain things, including some of the opioid receptor genes variations that actually affect the outcome in terms of pain. So they may still complain of pain even though they don't have any pancreas. So gastroparesis is another issue. Many of our patients with chronic pancreatitis also have gastroparesis. So that becomes a major concern for these individuals. So they'll continue to have pain. The other thing is, which is an area of great interest because we're trying to address these, loss of islets resulting from islet isolation stress, hypoxia, inflammatory response to infusion, and there are different approaches being tried to limit the damage that happens due to that. So this is a meta-analysis that was published earlier this year. This looked at 21 studies between 1980 and 2017. There were 1,011 patients. 18 of these studies were adults, while 3 studies had pediatric populations. And what you can see here was that narcotic independence was achieved in 53.5%. And then you had so 53.5 in adult and 52% in children. Insulin independence post-procedure was 31.8%, which is very similar to that other study, that 3 studies that I showed you. But there is considerable heterogeneity, 47.7% in children. So it's, as I said, it's higher for the children than for the adults. The 12-month post-surgery A1C reported in 4 studies was 6.76%. So neither stratification by age of the study population nor meta-regression analysis, considering both study publication date and islet equivalent weight, explained the marked heterogeneity between studies. So that is still a big issue because these are, even though they combine all of them, there are 1,011 patients, but that's 18 different studies. So each study doesn't have too many patients in them. The post study is still ongoing. The recruitment is all done. They're now in the follow-up phase. We have about 450 patients that are being followed across 8 US centers, including one of it being ours. And we are looking, the data is being analyzed to look at multiple factors that affect outcomes, both in terms of pain and also in terms of islet function, insulin independence, other complications, and quality of life in these individuals. Now, coming to islet allotransplantation, obviously this is taken from a pancreas donor, and then the same procedure for isolation and infusion. This is the phase 3 trial of transplantation of human islets that was published in 2016, funded by the NIH. So it is, it's a phase 3 study using purified human pancreatic islets. So these individuals had type 1 diabetes for more than 5 years, absent stimulated C-peptide, and documented impaired awareness of hypoglycemia and severe hypoglycemic episodes despite expert care. And they used standardized procedures for isolation, and they used standardized immune suppression protocols. So the primary endpoint was achievement of A1C less than 7% at day 365, and freedom from severe hypoglycemic episodes from day 28 to 365 after the first transplant. So this gives you here these are the percent of individuals who are reaching the goal A1C. I mean, obviously none of them were initially, and then you can see here that you know, I think this is about 88% or 90% who had reached. You know, this gives you the data for both 365 days and 1 and 2 years over here, and then you have the hypoglycemia rates markedly decreased with the islet transplantation, and severe hypoglycemia is, you know, very low in patients who have undergone islet transplantation, and you can see their drop in the hemoglobin A1C. So there is significant improvement in A1C and in the number of episodes of severe hypoglycemia. So this is looking at the C-peptide response. This is initially when they don't have any response. These are I think the 75-day, 365, and 730, and you can see here that there is a restoration of insulin secretion with C-peptide increase in response to a mixed meal tolerance test. So the primary endpoint was met by 87.5% of subjects at 1 year and 71% at 2 years. Median A1C was 5.6% at both 1 and 2 years. Hypoglycemia awareness was restored with highly significant improvement, and no study-related deaths or disabilities. 5 enrollees experienced bleeding requiring transfusion, and 2 enrollees had infections attributed to immunosuppression. So GFR rates decreased significantly on immunosuppression. Donor-specific antibodies developed in 2 patients. So their conclusion was that transplanted, purified human pancreatic islets provided glycemic control, restoration of hypoglycemia awareness, and protection from severe hypoglycemia in subjects with intractable unawareness of hypoglycemia and SHEs. Safety they were very safe and should be considered in individuals with type 1 diabetes who have impaired hypoglycemia awareness and severe hypoglycemic episodes. So that's the thing that they had. This is a follow-up study of the same, looking at a longer period of time, and this was published in 2022, last year. And this looked at 48 individuals who had islet alone and 24 individuals who had islet after kidney transplant, and they were followed for 8 years. And again, there were similar goals, which looked at graft survival, stimulated C-peptide greater than 0.3 nanogram per ml, glycemic control of A1C less than 7%, freedom from severe hypoglycemia, and insulin independence. And again, what you see here is that you will have the islet graft survival at median and final follow-up was 84% and 56% for islet alone, 69% and 49% for islet after kidney, with 77% and 49% of islet alone and 57% and 35% of islet after kidney maintaining post-transplant A1C of less than 7%. So there is a significant impact. So even long after the initial islet transplant, that they were able to maintain graft function and also excellent A1Cs. So more than 90% of both insulin independence was achieved by 74% with islet alone and islet after kidney transplantation, with more than half maintaining insulin independence during long-term follow-up. So with this particular protocol that we have, you can have the median follow-up, I think, was about 4.5 years or so. So they have good outcomes. From the single center study, this is from the Edmonton study, which they first developed the Edmonton protocol, which is now widely used in 2000. So this is a 20-year experience. They've done 255 islet allotransplantations, median follow-up of 7.4 years. Graft survival was 5.9 years, and graft failure occurred in 36% of patients. So 70% had sustained graft survival, and 30% had non-sustained graft survival. So the other thing that they have is that you can see that over time, the insulin independence drops, so that at 20 years, they only have about 8% who have insulin independence. But at at the time years at 1 year, and then at 5 years, you have about 32%, and at 10 years, you have 20%. So there is a decline in the function of these islets over time. And that is something that has to be kept in mind. And they have used some other techniques which they're not, such as using anti-inflammatory agents like anakinra plus etanercept to prevent destruction of the islets by the immune mediated inflammation. And those were also some things that we are still working on to look at how they could be better. So the current recommendation would be, for who can get islet transplantation, it is pretty much the same as those who can get a pancreas transplantation. But the islet transplant procedure is much simpler as a technique, and so it does not involve a major surgical procedure. So more sick individuals can be candidates for this. And if they have preserved kidney function, then the main thing will be labile blood sugar, more than one severe hypoglycemic event per year. Then if they also have, renal failure, either you do islet after kidney or simultaneous islet and kidney transplantation. So the indications are still about the same as what you have for pancreas transplantation. So what are the drawbacks of this? Of course, there is failed islet engraftment, there is need for immunosuppression, and there is a scarce donor supply. So what can be done? You can look at alternative sites of transplant, local therapy to increase vascularization, mesenchymal stem cells co-transplantation, immunoisolation techniques, less toxic immunosuppressant regimen, then pluripotent stem cells or embryonic stem cells, and xeno-derived islet cells. So we'll talk about some of these that are being developed. This is a stem cell derived islet produced from the human embryonic stem cell by a step differentiation procedure. And one of the things that you can see here is that it has the three main, the alpha, beta, and delta cells are all seen here. So it can make all the three hormones. But one of the things that they do mention here is that there are other cells in clusters that did not stain for any of these three hormones. So that is important for us to note that there are other cells that are seen. So this particular technique of differentiating stem cells to islets was developed by Doug Melton's group, and this is looking at the human pluripotent stem cell, and through a 6-step differentiation procedure, they developed these islets. This is the stem cell. This is the control, which is hepatic cells, and then these are the adult primary beta cells. And looking at the glucose insulin response to glucose, it is similar to what you see from the primary beta cells. So this particular technique of developing from a pluripotent stem cell to islet was developed. This was published in Cell in 2014. And one of the things they also subsequently have done is that you can manipulate the differentiation process and you can get different proportions of, you can get a stem cell islets that are enriched in beta cells, enriched in alpha cells. You can get a 60-40. So you can do things to vary the composition of these islets. One problem, of course, is that when you do this procedure, we think that, since we actually don't know exactly how islets differentiate, when you look at the primary islet and look at the stem cell islet and look at how they respond, I showed you that they responded to glucose with insulin secretion. But when you look at the pathways and look at how they respond to glucose or pyruvate, to tolbutamide, and what happens to calcium influx versus using ATP-ADP ratios. So what you find is that they're not exactly the same. You will see that with glucose, it is similar. However, with pyruvate, these stem cell islets actually have a greater response than the primary islet. But when you look at the calcium influx, it is different. I mean, the stem cell islets actually respond less than the primary islets. So there is a difference in how these islets respond to different stimuli. So these are not, although we differentiated them using a process which we think mimics normal human islet development, it is not exactly the same. These islets are different from, and there are more details available in this paper looking at other aspects of insulin secretion. Of course, you make everything newsworthy. This is the New York Times article, which came out in 2021. This is the first patient who received the islet, which was developed using the 6-step differentiation process that Doug Melton's group had developed. And this is by the company called Vertex, which this is a 90-day data, the first patient in the first phase 1/2 clinical trial with this particular product, which they call VX-880. It's a stem cell derived therapy. And this particular person was able to maintain good glycemic control. A1C was down to 5.6% and was a 91% decrease in the daily insulin requirement. So he was not totally insulin independent. One of the things, and I'm not sure exactly what the reasons were, because this is a commercial product, it had to go through the FDA. So they were required to use less than what they thought would be the required dose to correct fully the glycemic problems. So they used less than the expected dose of stem cell islets. So he was able to maintain it, although there are subsequent reports which indicate that there is a decline in islet function. But one of the advantages that is considered here is that if we can manufacture it, then it is possible to refuel it. You can go and have some more. So this is so currently there are 2 companies that have stem cell islet programs that are in phase 2 and phase 3 clinical trials. Vertex is the one that I showed you. The other one is ViaCyte, and they have this procedure, which is a pluripotent stem cell derived pancreatic endoderm cells. These will differentiate into into islets. And there's a particular procedure, which is actually a macroencapsulation procedure. So this is actually put into this device, which is then implanted. And this has also shown good C-peptide response. So in the first 26 weeks is what they had this initial study, and they were able to show that this is also a viable option. So it has moved on to clinical trials of using stem cells for islet transplantation. So one of the things that you can do with with islet, this development of stem cells, is that you have opportunities to improve some of these things. That means you can look at the islet function, and then you can look and see if you can change some of the composition of these islets to get better responses. You can also use the immunoprotection devices such as encapsulation, which is what ViaCyte has done. And then the other technique that they have used is also looking at using CRISPR technology to actually modify some of the genes that are expressed to make them less immunogenic. So you have more survival of these islets. So the key pillars for successful islet transplantation is to generate highly functional stem cells. Then you have to have the manufacturing at scale, because if you only develop 1 million cells, it's not, it lasts for one person. So you should be able to actually generate a large amount of these things. So that is very important. And once you transplant it, you need to have an optimized dose, the best site of transplantation, ways to decrease cell stress, and adequate nutrient supply. Because whenever we do this immunoisolation procedures, particularly encapsulation, nutrient supply is going to be a problem, because if things can't come out, things can't go in either. So if you if insulin can come out and then if proteins can go in, then immune proteins will also go in. So that's why that's a bit of a problem. So there are significant advances in each of these to try and see if this can be possible. So the critical quality, when you look at the function, secrete insulin in response to glucose and secrete oxygen, that's something that has already been done. You can get strong first phase insulin response. You can, in diabetic mice, normalize blood sugars and improve glycemic control in humans and non-human primates, but these are still a problem. There is a lower overall insulin secretion than primary human islets, and there's weaker second phase insulin secretion than primary human islets. So this is something that we have to look at. Then here is the gene expression. So you have all of these different genes, but also expression of some of the beta cell maturation markers is low. So these are the main maturation markers that they're looking for. But that tells us that maybe these islets are not as human as they should be. Then you have the accessibility for endocrine identity genes. So there are some issues related to that. One of the things that we find is extra cells. There are some enterochromaffin cells particularly. So that's an issue in the long term as to what will happen to those. So those are things that we have to be aware of. The composition, they do contain these, but off-target cell types are present, especially, as I said, enterochromaffin cells. And again, their role, and the most important thing is to control the relative abundance of these cell types. So you don't want an islet that has functioning beta cells and alpha cells and delta cells, but also has a whole bunch of other cells, which we don't know what they're going to do. So this is one technique that was used again by Doug Melton's group using CRISPR screening. And one of the things that they were able to do was that they were able to identify that this interferon gamma receptor that was critical to the immune rejection that was occurring. So they could then modify these islets so they don't express this FN gamma, or it is blocked by a different expression of this knockout of the CXCL gene. So then they were able to show that this will not be rejected. Then you have another way of addressing this, which is by simultaneously using some other types of cells. And here what you have is they have some of the mesenchymal cells that you can have that will actually block the immune system from destroying the islets. So even though there is a T cell response, these there is local immune tolerance. It's not systemic immune tolerance. Then there's another technique that has been used, which is to use adipose-derived mesenchymal cells, and they can be differentiated and also. In this, one of the other things that we notice is a significant loss of beta cells in particular. After transplantation, there is about 50% loss of islets, and there is a 70% loss of beta cells. And some of it is due to cell death, some of it is due to dedifferentiation, some of it is transdifferentiation, and some subtype conversions that are there as to functional versus non-functional. So this was an article that was published earlier this year. So this is by Shapiro's group. They are the ones from Edmonton. And we have been looking for advances in this field. And in 2022, there were some significant advances. One, of course, their own publication of the 20-year data from the thing. Then the biocides, the immune device with stems, with islets. Then you had the thing that I said about co-transplanting mesenchymal stem cells, where that secreted CTLA4 and PDL1, which blocks the immune response locally. And then detailed characterization of these, and then the mixed lymphocyte response, the one that, using CRISPR gene editing target, trying to improve survival of these islets. So there has been significant advances in this field. So this is the future of islet transplantation, that you have islets, you have the progenitor cells, and then you have the isolation and purification of human islets, add environmental cues, then then you have the differentiation and development of both the extracellular matrix and the stem cells, and then of course transplanting into the individual, looking at the traditional. So if you have more than 70% viability, more than 50% purity, if you can get a dose of more than 5,000 islets per kilogram body weight, then it can be transplanted. And there are other things where you can use a device to make this, prevent immune rejection. The adipose-derived mesenchymal stem cells, these are much newer, and these have been used. One of the advantages is that they can be differentiated into islet cells. They also, if you co-transplant them, they will preserve residual beta cells, help engraftment, and support function of the pre-cultured islet grafts. So the benefits and hurdles of pancreatic beta cell thing, you have the pancreas transplant, islet transplant, embryonic stem cells, and induced pluripotent stem cells. Here we have donor shortage, but the responses are very similar to what the human islet is, because they are human islets. And immune rejection is still an issue. Human embryonic stem cells, there are some ethical concerns, but there are still issues in terms of how much we can generate them, and the beta cell functional loss that occurs over time. And with the induced pluripotent stem cells, which is what is being currently available, there's still, they are polyhormonal, immature, and undesirable cell lines are still there. And these are different ways that people are trying to address these problems by using different technologies. So we have, currently the state of the art is insulin pump with a sensor. So these are kind of the common things, and there are some, with beta cell replacement, this is common to both the advantages, which is benefits of more time in range, less hypoglycemia, less glucose variability. There are also psychological benefits of, reduced fear of hypoglycemia, better sleep, more confidence, all of those. The challenges of cost, coverage, access, support remain for them. And then there are some advantages of the beta cell development: freedom from diabetes, biological solution. You're not attached to a machine. There is minimal user input. Once you have the transplant, you don't have to do anything. Risk of immunosuppression, anxiety regarding immunosuppression, limited access, durability, and is it scalable? Those are issues that are here with beta cell replacement. And here, of course, is It is less time consuming, no immunosuppression, upgradable technology, and easily reversible. But again, they're still dependent. There's ongoing maintenance, significant user input, and residual risk of hypoglycemia or decay. These are all issues that are there. Now, this is the data currently. This was published earlier this year, looking at how many islet transplantation centers are in the world. There are 69 programs covering 84 centers and 5 networks. And one of the things about the United States is that since the islet transplant registry and the Clinical Islet Transplant Consortium funded by the NIH is no longer operative, the number of allo transplants has dropped significantly, because in the United States, the allo transplant is considered as is regulated by the FDA, and it requires special approval, which is very expensive and time consuming. So there is no company that has come forward to put that thing. Whereas in Europe, this is an approved procedure, and it just goes through standard, any surgical procedure type of thing. So you don't have to worry about. So here it is considered a modified organ. So it comes under a lot more regulation than just any other surgical procedures. There are not very few sites outside of the US and Europe that perform these. So that is still an area of concern. So beta cell transplant replacement has advanced significantly. Pancreas transplant is effective and safe treatment that is underutilized. Islet autotransplantation offers significant success when used in appropriate and selected individuals. Islet transplants success has increased, and in Europe, it is available for routine clinical use. Stem cell transplant has also made significant strides, and several clinical trials have entered phase 2 and 3. And then there's ongoing research to improve immunosuppression, immune modulation, and immune isolation methods. So I'll end it here. I'll thank our surgical colleagues, the Islet Lab, my previous mentors, Dr. Samuels and Stagner, Dr. Winters, who encouraged me through all of this, and then our transplant coordinators and other people who worked, including our fellows and others who have been involved in these procedures. Thanks, and we'll be happy to answer questions.
Sri, maybe you can clarify when you have the embryonic stem cells and they are developed into beta cells. Is that done by growth factors and media differences? And what exactly are the stimuli which allow the stem cells to become beta cells? What do you have to do?
Correct. I mean, there are multiple things that they do. There are some growth factors that are used, but there also use some transcription factors to both increase and suppress some of these through that process to try to differentiate from one stage to the next phase.
So it's all things added to the media. They don't
Correct.
transfect the cells with anything, do they?
Yeah.
They don't. Okay. Thank you.
There's a question here about what are the criteria for cadaver donor islets. So pretty much when we, it is the same as we look for pancreas transplants. So obviously, individuals who are not, who don't have any diabetes and normal blood sugars, no history of any pancreatic disease, family history. Those are the things that is looked at to for a cadaver donor islets. So it's pretty much the same as what you would look for for a pancreas transplant. One of the differences, of course, is with pancreas transplant, the time window is small. Here you have a larger time window. So the the way that we can do increase islet vascularization after transplant, currently there are a couple of techniques which are there. Sometimes we can use vascular growth factors. The other thing is to also simultaneously transplant some endothelial cells. So one of the techniques that was being studied here was using stromal vascular fraction from the adipose tissue to co-culture them with the islets and to transplant them with it. And certainly in animal models, it does hasten vascularization.